We would like to welcome you to this session on preventive care using digital health technologies and screening tools to prevent and manage conditions. We have 6 speakers to this session, so we are looking very much forward to welcome you. This is an online session, so if you have questions, there will be questions after the presentations. We will use a microphone. For the online session, the audience will not be able to ask questions to the panel. But I will also have to say that this session will be on the ICA's homepage right after this session. So please go and have a look. I think this is a very good service. So the first presenter today is, just a moment. All this technology. Hey, where did it go? Monica, you are the first presenter.
I can.
Yeah, Filipa?
No,
Filipa,
this is mine.
Homem? No? You're the first presenter?
Yes.
Please, the word is yours. And we won't do the traditional long presentations because you can all in the app for this conference read about the presenters. So please, the word is yours. Here's for the...
It's just like
yeah. Okay.
Hi, good morning. My name is Filipa Homem, and I'm representing this amazing group that leads the COIMBRA United by the Heart project in Portugal. Imagine a healthy young man. Walking by COIMBRA in Portugal, he saw information about cardiovascular health assessments. He has no idea of his health status, so he takes the opportunity to have his heart checked. During the assessment, his cholesterol was above 200 and his blood pressure was over 180. The healthcare professional could just say what everyone already knows, that you should be more careful with his diet and should stop smoking. Would it be effective? I doubt it. But what if there was a different way to motivate people to a healthier lifestyle? What if, during the assessment, you were told that despite being 40, your heart is of a 60 years old man? The perspectives change. SCORE is a European recognized scale that allows calculate the heart age. And this is how our community intervention project is different. Since 2016, COIMBRA United by the Heart has been a community intervention which intends to promote healthy lifestyles based on the assessments of cardiovascular risk and interactive and playful strategies to prevent cardiovascular disease. With a team of over 100 healthcare professionals, both from hospital and primary healthcare, this project aims to empower healthy lifestyles, encourage the use of public transportation, identify and raise awareness about cardiovascular health problems, and qualify demand for primary health care for health surveillance. I will try to put, because image is better than words. Since 2016, almost 3,000 assessments have been made, in which was found that almost half of the population has least moderate cardiovascular risk with high cholesterol, high blood pressure, and sedentary lifestyle. All data collected are introduced into individual electronic health records, and all citizens with no primary healthcare surveillance were summoned by their family healthcare teams. 6 months after assessments, online surveys were performed to evaluate projects' impact. 85% of citizens were very satisfied with the healthcare team's performance in terms of availability, knowledge, and communication skills. After taking part of this assessment, 30% changed their lifestyle, becoming more aware of their health status, taking more health surveillance, getting better physical exercise, eating, and stress management habits. When asked if the project motivated them to seek health surveillance, 23% said yes. 40% reported they didn't feel the need because they were properly monitored in primary healthcare or cardiology. Evaluating the usefulness of the project, between 1 and 10, project was rated 8.7, and that should continue. There is a report from a participant who said that thanks to the project, I finally met my family doctor. He was 55 years old. We are replicating this project in non-Portugal regions with higher cardiovascular risks, promoting awareness about cardiovascular health problems, and qualifying demand for primary health care for health surveillance. I would like to thank the opportunity to show COIMBRA United by the Heart, a project in Portugal which uses interactive screening tools to prevent cardiovascular conditions in this great conference. Thank you.
Thank you very much for an interesting presentations. I would like to give the floor to the next speaker. That is Dr. Monica Perez Jolles. Is that, yeah?
Jolles. I know it's hard. Okay, so I think I'm...
So please, the word is yours. Can we change slides? Monica? So please.
Are we good? Am I second? We're checking. Sorry, we're checking to make sure I am the second presenter. Thank you. Just move it forward and check. I am next. Am I good to go? All right. Well, good morning. My name is Monica Perez Jolles. I know a handful. I come from the United States, University of Colorado, and my area of work is on health services and implementation science. So with our lab, our core program at the university, we work on how do we best deliver the solutions that you work on. So we focus on that area. So for today, I'm going to share with all of you a few concrete strategies or approaches that we use for developing and designing a screening tool for cancer prevention and management. All right, so let me make sure I don't go over my time. No conflicts to report, that's what we often do in the States. And here are some of my colleagues in the Implementation and Science Lab at the university. Funders, as well as other colleagues in the field that I'm citing throughout my presentation. Here is how I'm structuring the presentation. A little bit of background, I can't see very well. Then I'm going to describe how do we do this. The participatory engagement approach that we use, very focused on co-creation and user-centered design. I'm going to, very briefly because of time, share application in one case study and a few lessons learned or take-home messages. So let's start a little bit with background. From the delivery aspect, context, I'm going to move this a little bit. All right, now I can see. All right, so as you may know, for the fields where I just mentioned, implementation science, health sciences, as well as health equity, context is incredibly important when we are designing, evaluating, and delivering interventions or programs. And that means two things that I wanted to highlight. The first one is that one key step is for us to map those local contexts where we are going to deliver the solutions that you might be developing or evaluating. Number two, how do we do that? Well, we really need to engage the key partners that you think are important in that delivery, design and delivery of your solution. And our goal is to make it successful, that your solution is fully adopted, successfully implemented, and sustained, right? Those are our goals. A little bit more on context. The context where we deliver those solutions can really have an impact before, during, and after our evaluation or implementation of a program. So with all of this in mind, that's where I'm heading with how did we go about designing these screening tools. As you know, context is everything and really reflects the needs, characteristics, goals, and resources of those local systems or communities where we are going to implement something new in this case. All right. So how do we approach this design and this effort from a participatory engagement approach? We use co-creation to design and align a health screening tool to local clinical contexts. And I'll share with you key highlights of how we did that. Before I wanted to define, it's important to define what do I mean by co-creation. So we approach this design of a screening tool from a co-creation engagement and then looking at systems, complex systems concepts. This is how we define co-creation. There's more than one definition, but for us, it's a type of engagement, in this case in research or evaluation, where we bring our key partners to build the knowledge and direction in one of more of those areas. In our case, for our project, it was on the design and development of a cancer screening tool. Then we also pull from the concepts of core functions and forms from complex systems literature, originally created by Penelope Ha from the University of Sydney. We were very mindful that cancer care clinics and primary care are very dynamic, evolving environments or contexts. So we pull from these two concepts. They sound very abstract. Here is how we define them. Core functions, thinking of the purposes or goals of your solution, your intervention. What is designed to do? Without those functions, without those purposes, you don't have an impact. So what is the program or intervention designed to do linked to a mechanism of change? We preserve that across contexts, across clinics, communities. We want to make sure we reach those purposes. But then the forms are flexible, is the how. How we deliver that intervention or program in a particular clinic, in a particular school, in a particular community, that is tailored, that is customized to make it successful, impactful, feasible, and sustainable. So we pull from those two concepts, and what did we do? We conducted a series of hybrid. They were in person, but also using Zoom, virtual workshops. So they were hands-on working sessions, and we identified two groups of partners that were key for our project. Yours might be different. For us, they were clinic personnel from primary care for cancer prevention, and for palliative care, or those newly diagnosed with a cancer diagnosis. And we also included patients in our workshops. What do we do with our partners? We convene to refine those core functions. We are at the very beginning, and that's what we wanted. We wanted to bring our partners during the design and development of the thing, the screening tool. So they have a voice when it matters, not down the road where we cannot really make changes once we design the tool. And we started with those core functions. And I'll share a little bit how we did it. And we also work on both, the why and the how, core functions and forms. We facilitated the sessions, and we embedded into the sessions concrete ways, evidence-informed ways to prioritize and make decisions. And again, this approach allows us to tailor the forms, the screening tool in two settings, in primary care for prevention and also oncology clinics at the university. We use a user-design thinking. I don't have a lot of time, but very briefly, we started from hearing from our partners. We presented the idea, this idea that we had building on our colleagues, one of our colleagues' projects. And we heard from them on their challenges. How do you feel about this screening tool? How do we do this? And then we define the problems. We define their preferences. We embedded those into a prototype, and then we did some user testing sessions with our partners and clinic personnel to see, did we get it? How are we doing this? This look like what you suggested before we even launch or we even start evaluating our screening tool. So those were the highlights. Let me share now how exactly we apply this. How do we exactly went about doing this? This is one of our projects. It's a specific, I know it has a long name and a very interesting acronym, IIC3CP. Sounds like Star Wars, if you are a Star Wars fan. I am. So this particular project, talks about we focus on the design and development of a screening tool for new patients, older patients with a newly diagnosed cancer condition. So these are new patients with a cancer diagnosis. And you can see my team colleagues. We built on one of our colleagues' projects. It's called Whole Health Report. It's an online tool, a little bit about what is the thing, the intervention. My Whole Health Report is an online screening tool where patients can go in advance before they see a provider, and they see questions about their lifestyle and about, in other words, social determinants of health. But they get asked questions about their needs, transportation, about housing insecurity, but also questions about their lifestyle. And we started there, looking at this screening to then adapt it to newly diagnosed cancer patients. We focus on older patients, and we included the GA fragility assessment as part of this design of the comprehensive tool. What was our goal? Our goal was for us to be able to integrate the GA fragility assessment and this lifestyle tool into the early treatment development plan and conversations of newly diagnosed cancer patients to start in a place where providers know about broader comprehensive needs of these patients, not just medical. This is the GA that I mentioned. It has questions such as weight loss, food intake, mobility. And this is a prototype of our AIC3 screening tool. As you can see, we ask questions about how they perceive their health, problems with eating, taking in food, lost weight, but we also have questions that I don't have here, again, about transportation, housing, and other areas. So we have an idea of this tool. We didn't start it completely from scratch, and then we conducted the workshops. You can see here how we approach. We have themes for each of the workshops. Here are 3. But I wanted to highlight that we started from what is the value of this tool for you clinical partners, for you patients. And we definitely ask about the core functions or the purpose. Here is what we have in mind, and here is what we think can help, the why. Did we miss something? So we asked them, did we miss something? Is this important? We conducted several sessions with clinic personnel, with about 15 clinic personnel at different roles. That was important. Upper middle managers, as well as service providers, as well as those directly exchanging with patients, as well as between 10 in one of the projects, 5 and 10 patients themselves. So here are concrete examples. How do we go about understanding the local context? Organizational perspective. So we included managers in the service line to be part of the workshops. Patient perspectives. So we included them early on. And the external environment is a great tool to ask about transportation, but then we need to do better. So we embedded resources in the community for them to also say, yes, I do need help with transportation. Then they can click and receive services in their community for that. How do we do co-creation? So a few highlights. We including early on a steering committee. Number 2, we focus on the core goal, the purposes of this tool. We started there. If it's not meaningful, it's not going to be used. It's not going to be implemented. If it's not feasible with the forms, it's not going to be sustained. And then, third, we include diverse patients in terms of their diagnosis and age and lifestyle trajectories of pathways. All right, so I mentioned functions and forms. Here is an application, concrete examples. That can be very helpful because these terms are kind of abstract. And by the way, we never say functions. We never use that word with our partners. So for this project, one core function was, no matter what, we need to have better informed conversations from providers and newly diagnosed patients that address in order to better build and develop a care plan. So that's our goal. How are we going to do that? Developing this tool, referring patient preferences to the care team early on so they have that information to include it in the conversation. So for the screening tool, you're not only asked, do you need help with transportation? You're also asked, and you can click, are you ready to address that with your provider? Or any other questions of the lifestyle. So the patient still has control on saying, yes, I'm ready, or not. Leave it in my system, but I'm not ready to address that. Here is the timeline. How did we sequence these steps or these phases? Thinking from implementation science, we were just exploring and understanding how to do this. That's where we started engaging our partners through these workshops, and again, really focusing on the core functions and the environment. Then we moved to the pre and planning phase with internal pilot funding, where we started doing some prototyping and user testing sessions, and now we're heading to the formal testing. We often start on the right, so we're trying to bring it earlier to co-create with our partners, again, the knowledge and the direction of where we're heading. I know I'm running out of time. And we use concrete tools for tracking our partners' recommendations. You can see there, and reporting, did we follow your recommendation partially or not, and why? And it's important to get back to our partners and share, this is what we did with your valuable input and voices. A few home take messages is critical. It was critical to involve our partners during the pre-implementation exploration phase of an idea of a solution. You might consider that, or if you have done it, I hope you found it helpful. And active engagement and using systems, co-creation and systems thinking was incredibly helpful. Thank you.
Thank you so much for a very interesting presentation. We would like to give the word for the next presenter, Dr. Cato van Schyndel from Belgium. Please, the word is yours.
Okay. I hope I'm not too tall for this microphone. I'm not a doctor yet, so just to correct that. Welcome to one of the first sessions at IJIC 24. That means everyone's still fresh, hopefully. My name is Cato van Schyndel. I'm a PhD student at VITO, which is the Flemish Institute for Technological Research, and KU Leuven University in Flanders, Belgium. And today I'm very excited to present to you our research that we are conducting on digital solutions for disease prevention, mainly focusing on the perspectives of citizens, but also care providers, companies, and governments. Maybe to contextualize our research a little bit, I don't think that I need to explain to you all how healthcare systems worldwide are under significant stress. However, digital technologies are offered as a solution to this urgent or pressing issue, or part of a solution. However, with these digital solutions, as they create a vast amount of personal data, there are some issues related to uptake of these technologies due to privacy concerns, trust, distrust in certain stakeholders. And therefore, in Europe, the European Health Data Space is being set up to regulate this. However, in the run-up to a political provisional agreement, there was and still is a lot of debate on the role of the citizen in this whole narrative. And therefore, with our research, we aim to investigate how the citizens want to participate in the governance of their health data. So how did we do this? First of all, we conducted a systematic literature review of 36 international reviews, focusing on the citizen perspective on citizen participation in health data governance. And then second, we also conducted workshops with citizens, primary care actors, governments, and companies to capture their perspectives on digital technology solutions in disease prevention. And ultimately, our objective is to build a model for citizen participation in health data governance. Maybe to look at the results first from the literature review. When we ask ourselves, or the literature, the question, do citizens want to participate? We see a clear yes. So citizens are currently not very aware of what is happening with their personal data, but would like to participate more. So there is a willingness to participate. And therefore, for our model, as the outcome, we put a participatory health data governance. However, there are some factors and actors that have an influence on whether we reach this outcome or not. And first of all, a very important condition is trust. When trust in stakeholders is present, citizens are very willing to participate. However, there are some factors and actors that influence trust, so it's a mini model in this bigger model. I could talk a whole 10 minutes about trust, but for the sake of time, I will keep it short. So first, what we see is, in general, lower levels of trust are present in for-profit stakeholders to share data with. And for nonprofit, we see higher levels of trust. So primary care actors, health institutions. And then two concepts that are very important factors that have an influence on trust are transparency and control. We see transparency, on the one hand, can have a positive impact on trust, but it's not, transparency can also have a negative impact. And for control, we see, for example, when trust is present, less control is desired over the data, and it goes the other way as well. Now, next to this trust mini model, we have other factors having influence. Privacy. On the one hand, concerns relating to privacy can have a negative impact and lead to no participation. This can be in the form of a lack of data security or a perception of this lack. Abuse, misuse of data, and also when it comes to more sensitive types of data. And then on the other hand, as a counterpart, privacy assurance can have a positive impact and leads to willingness to participate. This can be in the form of data security, but also responsibility and accountability measures that are in place when things go wrong. And then we see some data uses or secondary uses that are supported and also unsupported. We see, for example, unsupported use relating to commercial use, and this also relates to lower levels of trust in for-profit stakeholders. However, what can have a positive impact is really showing the benefits of data sharing with citizens. This can be public benefits or personal benefits or both. And then lastly, to make the model more complicated, we have socio-demographic factors that have a significant impact on trust, but also on the ultimate outcome. We see, for example, age, gender, health status. All these factors have a significant impact. Now, if we look at the output from the workshops with citizens, primary care actors, companies, and policymakers, and we put these perspectives next to the model, we see, in general, active citizen participation is really valued by all these stakeholders in health data governance, but also in innovation in general. Second, we see relating to socio-demographic factors, age having an impact. We see older people with less privacy concerns, younger people with more or less privacy concerns. We also see digital and health literacy really stressed as a very important aspect, and that technology should not broaden any existing gaps. And then lastly, the role of the primary care actor or care providers in prevention is highlighted. However, due to a lack of time and resources, it's suggested that a broader collaboration is set up, so care organizations, research groups, governments all collaborating to foster this innovation ecosystem in which technology plays a crucial role. Now, if we put our model to the side for a second, and we look at WHO, they have developed a community engagement strategy with 6 guiding principles that provide a value base for a community engagement strategy. We see trust, accessibility, contextualization, equity, transparency, and autonomy. And when we take our model back, we actually see a very nice match between these community engagement principles and our model. So for example, trust, an exact match, accessibility and equity relating to socio-demographic factors, contextualization, which relates to citizens understanding or realizing the effectiveness and time-worthiness of community engagement. And then we see transparency and control, autonomy relating to control. And due to this very nice match between these community engagement principles and our model, as a next step, we aim to increase the uptake of digital solutions through a community engagement strategy, more specifically with a local intervention aimed at data sharing in a health promoting setting. Thank you for your attention. If you're interested, 2 of my colleagues who are here as well in the room are presenting on Wednesday. Nathalie Lambrechts is presenting a digital solution that we developed for disease prevention on a community level and the lessons learned there. And Charlotte de Klerk is presenting how this governance model can look like in practice and the role of citizens therein. Thank you very much.
Thank you so much for a very interesting presentation. I would like to give the word to the next presenters. That is Karen Kelly and Martin Curley, who's going to talk about combining clinician skills, patients' empowerment, and AI tools to predict and prevent cardiovascular risk factors and events. It's a case study. So please, the word is yours.
Good morning, everybody. I'm Professor Martin Curley. This is Karen Kelly. We're going to do a double act here, and we're going to talk about 4 things. We're going to talk about a big vision for fixing healthcare globally. We're going to talk about the 6P principles around prevention and proactiveness. We're going to talk about how we can use next generation screening and AI tools to identify cardiovascular risk and mitigate it. And then lastly, we're going to give a patient case study. So we want to move from a paradigm of too much too late to stay left, shift left. So we're trying to put forward a new logic and a new doctrine for transforming healthcare. We call that stay left, shift left, 10x. Stay left is about keeping well people well, or if you have a chronic condition, we can treat you best of all from home. Shift left is about getting patients as quickly as possible from a hospital setting to a home setting. And 10x is the idea that we can do things 10x better, 10x faster, 10x cheaper by using digital technology. So this is our vision. This is called the Manhattan Manifesto, and it's a vision of a new kind of health system, not an illness system, where people are at the center. And it's about moving from activity to outcome. So it's about changing the business model. It's about moving from treatment to prevention. It's about moving from fragmented and physical buildings to virtual and integrated care. And obviously integrated care is the theme of this conference. And importantly, it's about moving from passive recipients of healthcare to participatory participants. And it's a shift from hospital to home and from illness to wellness. We're based at the Innovation Value Institute in Maynooth, Ireland, and for the last 17 or 18 years, we have been working on bringing the benefits of the digital revolution to all. We know that 80% of cardiovascular disease is preventable, nutrition, exercise, and many other things, and that's what this particular presentation is about. So I'm going to hand you over to Karen, who we'll talk about the case history, and we will then talk about the 6P framework.
Hi, so we're going to talk about a case history, and this is basically a case history of a very active, fit, healthy, middle-aged man who, his only risk factor really was that he had a very stressful job. He was a non-smoker and very active and fit. He had quite a few consults with his GP and a cardiology consult, but he had... Please move closer to the microphone. Yep, he had uncontrolled hypertension, and his diagnosis was unresolved, so it was still uncontrolled despite being on numerous medications. Panacea Flow is an ANP-led cardiovascular screening that was looking at using AI tools in the community to do screening with a difference, where that we could screen people using point-of-care tools, where we could give people results at a time when they were doing screening, so they were coming for screening, so they were ready for education, so we wanted to educate them at the time. And if we found somebody who was hypertensive, that we did 24-hour blood pressure monitoring at the time. If they had arrhythmia, that we could do a Holter monitor, thereby reducing the whole time that it took to put them back to their GP, to put them into waiting lists. So we wanted to take a time from maybe 6 months to bring it down to a couple of weeks to get it all done. So this gentleman attended one of our screenings. It was a pilot program that we ran with the IVI in Maynooth. We did an ECG on an AI ECG that I'll show you in a minute, and his basic ECG showed that he had LVH as a result of his long-standing hypertension. We did an ambulatory blood pressure monitor, which showed that he had still uncontrolled hypertension. We had a smart cardia, a 7-day Holter monitor, which showed that he had paroxysmal AFib. He also had elevated LDL-C, and he had an elevated HbA1c, so he was in the diabetic range as well. So the advice at the time was that this man attended his GP to have his antihypertensive meds increased, that he was started on a statin, and that he also would be seen urgently by a cardiologist. So this is the AI ECG. It's a fabulous ECG that's held by Heart Science, and it's a MyoVista ECG, which the actual AI tool is the colored tool at the bottom, and it looks at the wave of your ECG. It looks at the relaxation of the left ventricle, and by doing it, it can actually diagnose diastolic dysfunction, which is the one part from a cardiology point of view and from heart failure. I'm a heart failure AMP. It's the hardest thing to diagnose. It's probably the most prevalent as we get older. It's the most prevalent heart failure disease, and it's also from lifestyle point of views. This is a great tool for people with diabetes. It'll also reduce waiting lists for echoes by about 40%. So we were very lucky to use this tool. We were the first people in Ireland to be using it. This tool highlighted that this gentleman, he had a very low energy in his heart, and he also had a very positive ECG, so it was kind of a red flag saying he needed a cardiology review immediately. And his Novacor blood pressure monitor showed that he was actually needed to have his hypertensive meds increased. Unfortunately, this gentleman, we told him that if he developed any chest pain between the time of seeing a cardiologist to go straight to A&E, and unfortunately that did happen. He developed palpitations in the middle of the night, and he developed chest pain, and he attended A&E, and he was diagnosed with AFib and a non-STEMI. And he had to go straight to the cath lab, where he had an angioplasty for a totally blocked right coronary artery. And he was referred for a CABG. The patient was very, very lucky that he actually, in collaboration with his cardiologist, they had a good conversation. He really did not want to have a CABG, and he went and used an AI cardiobot, and with a lot of education, because he had had some with us, and he had done a lot of education for himself, and they had a good conversation. And from here, I'm going to pass this back to Professor Curley.
Great, thank you, Karen. So this is what an occluded right coronary artery looks like. This patient had that, and on the left is an unoccluded RCA. So I'm just going to show you a video. Actually, this is one of my favorite videos of all time, and this is what happens. You can see a blocked one is lighting up like a Christmas tree. So this is the image from the angiogram. So the patient prepared a presentation for the cardiologist. He was very reluctant to undergo CABG, and in 24 hours did research on the internet looking at the pros and cons of CABG versus PCI, and looked at what were the optimal therapies available, looked at, had an electronic health record, so was able to look at what was going on in the past with his blood control. And CABG is actually indicated over PCI if a patient actually has a blood sugar or pre-diabetic or diabetic issue. So the patient compared, what is the comparison between PCI and CABG, and then actually used an online cardiology bot to actually ask intelligent questions. This bot was using the European Cardiology Society knowledge base and asked some pertinent questions. And on the basis of that, made this presentation to the cardiologist, which essentially said that he would commit to intensive lifestyle modification, but strongly recommended, and the evidence showed that a stage PCI would be a better outcome than CABG. And as Karen mentioned, this is an example of what the patient did. He got an Abbott Freestyle Libre, and he was able to manage his blood sugars via exercise and improve nutrition, and brought his HbA1c score below 43. So what were the outcomes? The MDT agreed they would have, multi-stage PCI procedure. Unfortunately, a reflection of the modern stresses of our healthcare system. There were multiple cancellations of the PCI procedure, and the patient was moved to a private hospital where it was immediately done. The patient recovered fast. The patient is now back playing cricket, and the patient, really acknowledged the outstanding skills of the clinical team, particularly the interventional cardiologist, and their willingness to listen. But just to advise, so I was the patient, and that video of the right coronary architecture or artery being blocked, that is certainly one of my favorite videos of all time. And this is last Friday night, so I'm back playing cricket. I'm really sad to say I got a duck don't know if anybody plays cricket, that's the first of my life, but I did take a wicket. So I'm going to ask Karen to talk about the 5 Ps here.
We actually call them the 6 Ps because I believe that the biggest one is actually the person that's in the middle of it. So the 6 Ps is actually the person. So the person, everything should be around the person. And I think even when you're doing screening, you have to think of the person because not all people want to be screened. They don't all want to know. So it has to be person, proactive screening, getting out there, screening people and finding what we can find. Predicting disease early is because if Martin had been screened a year beforehand, not that he wouldn't have had stenting, but we could have had that of an elective stenting rather than him having to spend 14 days in hospital. Preventing disease is the most important, and I love what they're doing over in Spain and what they're getting out, and lifestyle education, promoting healthy lifestyles, and participating. So those 6 Ps I think are really keen. Conventional GP care of Martin's hypertension and his lipids, they just aren't satisfactory, but a 15-minute conversation with a GP, they just don't have the time. So it's trying to figure out how do we support GPs and help them. Early screening in a community for everybody. We have to try and push for national screening to prevent all of the GP department attendance. 80% of them is actually avoidable. AI-assisted tools can definitely help getting out there and screening in communities, even doing lipid tests in chemists and pharmacies. And a patient voice, health literacy and empowerment is crucial. Every heart attack can be considered a medical failure if we get out there and actually educate, prevent, predict, promote, participate, and put the person at the front.
Great. I think we leave it at that, but thank you.
Thanks a million.
Thank you very much for a very interesting presentation. Now we have a good time for questions. And before I leave the floor for the audience, I just have some questions for the presenters. I would like to hear Dr. Kelly and Curley, because I'm working on not prevention, but patient education and patients with atrial fibrillation. What are your next steps? This is a case study you just presented and very convincing. Have you made considerations for the next steps for your research?
Sure. Well, maybe I'll start and then Karen. So the idea is and the beauty, the 10Xs, these kind of solutions can scale rapidly and easily. So we're attempting to codify this into a whole process that can be, a mass screening, and Karen's company's Panacea Flow. We use a process very similar to Colorado, a living lab process for introducing these innovations. So our next steps are not just research, because it's about innovation and impact, so is scaling this. And we hope to have an announcement at our summer school in June where this process actually has been operationalized and is used with, targeted with a particular industry sector, and we're also working to have it introduced with one of the major health insurers in Ireland. They offer it as a service to their clients. Karen?
Using the tools and
Please talk into the microphone.
Sorry.
Thank you.
I suppose the biggest part of this was going out and researching what can we scaling it up, and how do we scale it, and what tools can we use to scale it. And I think we've done that, and we've gone out and researched it and found the tools, and it's about getting out to the people and how, and we found the tools that can do that. So, and thanks to the IVI, and putting it all together as an actual program. So yeah, well, I think we have done it, and we're hoping that we can do it. So.
Sounds very interesting. Now, some of the topics we're talking about when it's digital health and the use of digital health technologies are the skills of the patients. Now you are entering also the clinician skills, because e-health literacy, a technical literacy, because all this, there are many fancy gadgets you can use for monitoring your heart, and I can see a live core, you're using that as well. But are the patients able to understand the data they are seeing? So I would like to ask Monica, because Monica, you brought this into your study. Could you give us some reflections about how you say you make a sustainable tool, but how is it that we can incorporate patients with different kinds of e-health literacy, technical skills, and whatsoever? What are your reflections in your study?
All right, thank you for the question. So I heard the question is focusing on how to make it sustainable.
Yeah, but also to remember different kinds of patients, you know, and not the strongest ones who has the money to go down the street in the Apple store and buy an Apple Watch.
Yes.
Yeah.
All right. So sustainability is so important, and several key points on how to answer that question. When we included patients in the design, we made changes that we can see that it's going to make it more usable and practical for the screening tool to be embedded in clinical settings. Let me give you one concrete example. During our workshops, some of the patients shared that we did not have anything related to mental health. This is a cancer screening tool. We missed it completely. And they shared that having a new diagnosis of cancer can be triggering or traumatic for some patients. It's not an easy condition, of course, but some patients may bring already traumatic experiences, and they ask us, please include questions related to mental health, depression, and anxiety. So we created a whole section on the design of the tool that now included mental health, because our patients told us. Again, we missed it. Clinicians and staffy researchers, we didn't have that section. So those are examples of how having their input early on when we were working and paying for, because it's expensive to have an adapted online tool, is so impactful. It's going to make patients feel better. So the patient experience is going to get improved, and that has been shown, better patient experience, more applicability of what they are asked is going to increase sustainment. How do we maintain their feedback, patients' voices, throughout the project? We have a steering committee, so moving that steering committee, well, that's with clinicians, throughout all the phases, exploration, implementation, and evaluation is important, but continuing to have these workshops and sessions with patients when we are exploring, when we are designing, and when we are evaluating, and then when we are disseminating the information is incredibly helpful and important for sustainment. And sustainment for diverse voices, I heard something about that. We included patients newly diagnosed, but also those who have had a diagnosis for years. So they could teach us and give us feedback going back on their experiences from day one and what didn't work. So that also gave us diverse views and perspectives. I hope I answered your question.
Yeah, thank you so much. Then I would like to ask Cato and Filipa, what do you think about, do you have some comments?
Hi, I didn't use digital tools. I have paper tools, but I think it's very important to make people aware of that digital tools. We have in Portugal, I was talking with Cato in the beginning, we have in Portugal a health national digital tool that everyone has in this smartphone because of the certificate of COVID, and nobody knows its potential. When we talk about digital tools, it's very important to talk about interoperability between health records. Yes, we have many digital tools on your smartphones, but did the professionals had the access to them? It's very important to think about it, but so.
Yeah.
Yeah, I also think relating to health data governance, I mentioned in my presentation, from the literature, we can see citizens are very interested to participate. but there are also citizens who do not want to participate. I think there needs to be room for that as well, and I think those people need to be able to feel the advantages from health data use as well. So I think that needs to be explored, how that governance should look like maybe a trusted intermediary or something. Because it's very important that, as I mentioned, existing gaps do not broaden due to digital technologies or digital solutions.
Thank you so much. If you have any questions, please, there are microphones in each side of here, so please go to the microphone because it's a live session. There's one over by the door there, please. Are there any others? Because then you can queue by the microphones. Please go and be prepared. Yes, please do.
My name is Molu. I'm from the Netherlands. I have a question to Martin.
Please.
In your last slide, you state in small letters, but we got them, that every heart attack is a medical failure. Now, I propose that we always talk about putting the patient at the center, and you say we put the person at the center. What if you change that sentence to every heart attack is a cooperation failure?
I think it's absolutely perfect, and we should do that. And we were talking about patient education. The major issue at the moment is patients aren't educated and actually understanding. We already know for more than a decade that statins can not only halt but also reverse atherosclerosis. And when we talk about stay left, shift left, 10x. That's all about self-care and shared care, and I agree. But I think when this conference is held in 10 years, heart attacks should be almost eradicated. And the title of our slide, Kevin John Williams, he's a cardiologist in Temple University, and he's a fantastic paper talking about too much, too late. So somebody has a heart attack, and we've got to do the angioplasty. We've got to put high-dose statins, but if, as Karen had said, look, if we can identify issues earlier on, low dose of statins can actually reverse that. So I agree. In stay left, shift left, 10x, there are 10 Copernican shifts that we talk about. This is a major transformation of our healthcare system. The first 3 are from illness to health. We're spending 97% of our health funding on illness. If we just put 3% on wellness, a little bit more. The second shift is what you're addressing is from doctors know best to patients know best, this cooperation. And then the third is from hospital to home. So I think we're very aligned, and I'm glad that you don't dispute that a heart attack is a medical failure, but I agree it's a cooperation. But we need more informed patients, and the promotion and education is really important. But that's een hele goede question.
Thank you well.
Thank you well.
But I would just like that, it ties in with 2 other presentations from COIMBRA and from Belgium, that apparently trust is the main thing in every medical or whatever professional relationship that we have. So I was wondering, apparently your patient in COIMBRA has never, ever felt the need to get to know his physician. And isn't that a wonderful thing? Should you not have left it at that? Of course, you can't trust somebody you have never met, but it's very questionable to me that why is it a good thing that he got to know him?
Please talk in the microphone.
Primary health care, it's very important. The general practitioner and the family nurse is very important to maintain health, not only to prevent.
So to get to know each other and trust each other.
It's, I am a nurse at a cardiac intensive care unit, and that same situation. When I say to a healthy young man, you stop smoking, but when I talk to a man who had a heart attack, you have to stop smoking, and he instantly makes in that mind that he has to stop if he wants to live more and better. So in Portugal, we need, how can I say, in Portugal I used to say that who had a heart attack, your general practitioner and your family nurse will be your best friends in life. So you have to manage your risk factors, and you have to maintain. There are very many studies that said that 1 month after heart attack, the life becomes normal. So I would start smoke again. I will miss the medication. So it better gets there the general practitioner and family nurse to get. No, you will have a heart attack again. So you cannot. The reinforcement is very important. So
I think reinforcement is important, but only a little bit. Trust, apparently, is much more important.
Yes, yes. The reinforcement becomes with trust.
Yeah.
If I don't trust my general practitioner,
then how will the reinforcement? Yeah.
Yes.
Thank you.
Thank you. I think we have a question over here. Please present yourself before you ask your question.
My name is Roisin Malloy. I'm from a company, Trimedica, just based here in Belfast. And one of the things I wanted to bring up was, I think, Cato, you'd said at the start about the cooperation with lots of partners, including industry. And where individuals who have been in certain roles then find themselves in a position where they feel they must do something, like Karen, who set up the company to do the screening. That was my experience as well in setting up our company. But one question I wanted to ask you specifically was there was a company in the UK, and in the UK we can own our GP records, our GP information, but we don't own our hospital information. And what they did was they engaged patients to enable them to get access to the records. So then they could put it on this company's portal, and the company had this information. This meant then that, say, clinical researchers or other industry leaders wanted information or data that, for example, say it was a 50-year-old diabetic patient and they wanted these people for a study. The patients could decide whether they wanted to partake in that study. And generally what they found is if they had very bad experiences, they would generally want to have their information used so that they could help get solutions. But they paid them. So every time they took part, they got £100 in their pocket. A bit like what they do in the US for blood and other things, which I know that's questionable. But is this something that you have looked at or thought about, of a patient being able to use their data to move the knowledge forward, but also to benefit from maybe their financial or other compensation? And how would that affect the trust side of things as well?
Who wants to take it? Cato?
Is it a question directed at anyone?
Anyone. I mean, Karen has obviously set up her company to do just what what we're saying, which is screening to find the solutions. And Cato, you'd said that the big thing is trust. So has that impacted?
Thanks, Roisin. And can I just say thank you very much, because I absolutely love your product and I think it's amazing. So thank you very much. But it's not something that I have personally looked at, and I do think it's something that we could look at down the road, because I think if people, especially in the area that you talk about, diabetes, because anybody with diabetes is 40% at risk of cardiovascular disease, and I think they're an area that in our research and what we did, a lot of them aren't getting screened for cardiovascular disease, and they're not getting screened for risk factors. So by actually paying them to be screened, you're probably reducing a huge cost at the end of it, because you will catch a lot of disease early. So it probably is something that could be looked at, because if you catch it earlier, then you could treat it earlier. So you might actually prevent heart failure or prevent a heart attack.
Maybe could I just add to that, Roisin, two thoughts. Actually, Karen at the Innovation Value Institute, we're working with Karen on a next generation screening process, where at the end of the process, which is real time. And by the first thing we do is actually take a temperature with a tri-temp thermometer to see that the person has normal temperature. But at the end of the screening, we give the person a personal electronic health record on their phone with the summary of what we've learned in the screening. And the data, working with a company called Full Health Medical, we see that 1 in every 5 people that are screened actually have a risk factor that needs to be addressed. So the first piece is the next generation screening. The person will get a personal electronic health record that then empowers them to manage their health. Every country has a choice. If we look at it from an economic standpoint, there's a construct called a production possibility frontier. And almost every country in the world makes the choice to put all of their money in Europe, and in Ireland we put 97% into illness and just 3% into wellness. The one exception is Singapore. And Singapore have been moving on that curve, and they have a program where you actually get paid to stay well. Completing the number of steps, etc., and they will reimburse a Fitbit or an Apple Watch. But there are also incentives. When you actually buy healthy food in an approved store, you get points. So this idea of incentivizing behavior actually is the future. I recently had a conversation with the outgoing Taoiseach of Ireland, Dr. Leo Varadkar, and said, would the Irish government consider paying people to pay well? And he said, yes, let's look and discuss this. So I think back to the original point there, educating patients, empowering them with their personal electronic health record on the phone, and then incentivizing behavior and vitality. And some other organizations, you'll get a reduced insurance premium. That's the first bit. But actually paying people to stay well is really smart. It's great for the patients. It's great for the economy. We looked at the economics in Ireland. If we introduce a national screening process, and if we could avoid one overnight stay for 1% of the population, the program would pay for itself 3 times over. So this is certainly the future.
Thank you. Cato, did you?
I think relating to health data, we do need to be careful with tokenism and financially incentivizing people. Let's say people from more vulnerable environments. I think that's something to take into account and to not put all the responsibility on the individual, but make sure that the system supports individuals in this.
Yeah. Thank you. I think there's a question more. If there are more in the audience who have a question, please, there's a microphone over here. But please, will you introduce yourself and then your question?
Thank you. I'm delighted to be here in this session, and thank you to all the speakers. My name is Stacey, and I'm an informed patient, and I engage in research with different clinicians and researchers across our island. And I sit here today as a patient that has a live core monitor.
Please talk in the microphone.
Apologies. I sit here as a patient that has a live core monitor in her bag. So I really understand the benefits of technology and this type of technology. I suppose delighted to hear that you're scaling this up. Really concerned about the fact that you're aligning with the health insurance side of this. Because if I, as an informed patient, look at this, it's the socioeconomic side of this. Most people with cardiovascular disease can't afford to pay for private health insurance. So I'm wondering how you're going to scale it up to be equal for all.
Yeah, unfortunately, I think we need everybody. This should be the National Health Service, and that's actually driving this. Unfortunately, we experience extreme resistance in trying to drive this, in the Republic through the National Health Service. So I actually had to make the decision to leave the health service to do it from the outside. So, we're working with a particular sort of industry, a workers' trust where we're going to do the screening. We're working with an insurance company. We're working with 3 or 4 other partners to actually bring the solution forward. And we're using kind of non-linear systems change and the theory of emergence to actually bring this about. This, of course, should be driven by the National Health Organization. Of course it should be. And it's all about health equity and health equality, and it will come. But unfortunately, we've had to take a different route. But, you know, I think both of our commitments and everybody that's part of the Stay Left, Shift Left 10X was about democratizing healthcare and having the best tools, the best information available to everybody. So it's a tactic, but I would have to say I applaud this particular health insurance company for being very proactive and saying they want to do the best for their patients, but they'll be just one of a number of different actors. And ultimately, all of these things will join up. There's a quote from Ilya Prigogine. He was a Belgian, Russian Nobel Prize winner. He says, when a system is far from equilibrium, and that's what our health service is, small islands of cohesion have the ability to transform the whole system. So we're seeding in 5 or 6 places a next generation solution, and hopefully it becomes obvious this should be the national solution. Is that fair?
No, that's fair, but I suppose I would urge you on the side of caution, because when you are enrolling patients into this and they start their journey, the patients that will most value from this will be not those type of patients, and they won't have the literacy skills or the digital literacy. So you need to be very mindful in your design of what the tool and how you're moving forward. And I suppose in relation to Roisin's question, I would have great concerns ethically, especially on the EDI side of this, the equality, equity, diversity and inclusion side, and the comments from the other panelists in relation to tokenism of the pay side of getting people to move forward and with their digital technology and how they can improve lifestyle factors.
I just add to that, I suppose at part of the study that we did, a third of the study was actually carers. So they're very much at the core of what I'm about, and they're on the focus group. So there is actually 3 patients involved in the focus group in the design of this. So they're very much at the centre. So their voice will be there. So there is patients, and there is GP nurses involved in it as well. So they will be involved in so thank you for your input, but they are very much involved in design as well.
Oh, great to hear that, and I think probably you might need to scale up your PPI to ensure it's more inclusive, to have more than 3 for diversity.
Yeah, thank you.
Thank you. Thank you. There's time for another question. Please present yourself and then the question.
Okay. Friede Bock from Germany, pediatrician and health service researcher from Düsseldorf University. I have been listening, and I thought of the things that you said, that 97% are, let's say, illness-bound costs and 3% prevention. And if I think about your screening tool, the AI-based one, the problem will be that, I mean, that a lot of people actually gain their money through cabbage, through all these techniques. They have big departments where they have to have patients coming for the cardiac failure. So if you think about the system, I understand the tactic that you use with health insurance, with companies to try to get innovation and to show that it is possible, let's say. But how do you think about system transformation? Because I think those people now operating people with a heart attack or doing cabbages or something like that, they should be trained, or they should be enabled to make money out of the screening and out of the health education. So how to shift this?
I think, the business model, Michael Porter, who's a professor at Harvard, he said in healthcare, too many people get paid more to do the wrong things. So if we're going to implement this, we have to build a win-win business model. We're using tools like Alexander Osterwalder's business model canvas to design a new business model. And of course, we should, it is going to need retraining, and we need a massive shift. So in the future, in 10 years' time, as I said, the vision is almost nobody has a heart attack. There will be limited, and unfortunately that won't be the reality. We're still going to need people needing cabbage and open heart surgery. But it's all about designing this new innovation, this new healthcare system together. And we're using a methodology called Open Innovation 2.0 This is a methodology developed by the European Commission, Intel, and Maynooth University, where I'm from, and it's about starting from a shared vision and then having shared values and then creating shared value. So we have to collaboratively design this new healthcare system. That's what we call stay left, shift left, 10x, and we have to show a future which is better for patients, it's better for physicians, it's better for nurses and physios, and it's better for the government. And we already have quite a bit of evidence of 10x solutions, 10x better, 10x cheaper, 10x faster. One of the biggest issues is physician burnout and attrition, and clinician, but providing solutions that make the nurse's job a lot easier, or making a surgeon, so that is a way of, so it's about collectively moving together. And I do agree, vested interests. We have, you know, Eric Topol, who's the renowned cardiologist, he wrote the book, The Patient Will See You Now. You know, he says medicine is the most entrenched, most intractable industry in the world and the hardest one to change. But the way we are going to change it is designing for adoption, providing solutions that are so compelling that they immediately get adopted. Better for the doctor, better for the patient, better for the system. Thanks.
Okay, thank you. I think there's another question, so please present yourself. If there's others, please, the microphone is on each side of the room. Please.
Hi everyone. My name is Roseanne. I'm an OHT fellow from the University of Toronto. My question is about digital health solutions, and I was inspired by the presentation from Belgium, where we were taking into considerations, of course, building trust, and then having consent from the patients for the sharing of their digital, for example, information. My question is about accessibility. How will we be promoting trust if this patient, for example, does not have the technology, or they're not well informed, so they can't access the technology, or they because of other reasons?
Please, Cato.
Yeah, thank you for your question. I think digital health solutions, well, they're part of the solution, but I think people who prefer a non-digital solution should still have that right. Mm-hmm. And I think, therefore, like in the literature, it's also very clear. For example, a general practitioner, a primary care actor, they receive a lot of trust from citizens, and I think those care actors have a very crucial role in this whole narrative, and I think they are a person who can offer this digital health solution, but also give another option, a non-digital option, if that is what the citizen prefers, because yeah, I think people should have the right, if they don't want the digital option, that they're not forced to go in that line.
Yeah, please. Please.
Yes, completely agree with my colleague presenter. We did struggle, though, with that. So for the screening tool in cancer, we heard from clinics that they prefer online version of the tool. So patients go to their portal, and they complete it by themselves, and then the data goes automatically into the care team, into the system. So the care team has access. Notice how that workflow is easier and more efficient for whom? For clinics. So we had a concern because patients said we want what you mentioned, the option to complete on paper, because we have the digital divide and issues of equity and access. So here we have two systems with very different goals and preferences. So we decided to do both, complete it online, but the patients don't have access to their portal or even a computer. In the United States, we do have huge inequities in access to technology, that they can go to the clinic and do it in person. And what is the problem with that? That now the clinic has to pull someone's FTE, someone's time to sit with the patient and complete it, and in several languages. So first challenge. Now the implementation of the tool is more expensive. So feasibility goes down as we try to tailor more for access. So health economics are incredibly powerful force. Then not only that, but then someone at the clinic has to enter the data because it's on paper. So now someone has to spend time entering patients' data into the system to have the information. And this needs to happen so early on the care team can have access, review it, and have conversations. So this needs to happen really fast. So now, again, cost of and feasibility, cost going down, up, feasibility going down. We don't have yet the solution, but designing for implementation, designing for equity, and designing for sustainability early on is incredibly helpful. We're wrestling with these issues and early on in the design. And they are key in the early implementation of a solution.
Okay.
Thank you so much.
Thank you. There's another question. Please present yourself and then the question.
Hello, my name is Lina de Tour. I'm a PhD student at the Center for Contextual Psychiatry at KU Leuven. So I want to thank you all for very interesting presentations. I have a little bouquet of follow-up questions that I would like to fill out these last minutes with, maybe, if no one else has questions. So first, Filipa, very interesting work you're doing with health education. And in your results, as far as I remember, you showed that around 30% of the people that you engaged with said that they wanted to do changes, health changes in their daily life based on your intervention. But so my question is, what was your goal? Because if all of these people needed to make changes in their health, I would say like 30% is maybe, you would maybe want more to actually make lifestyle changes. I'm just going to run through my questions because then that's faster, I think. And then to Monica. Yes. Also very interesting work. I'm very happy to hear that you're using this participatory methods to develop your screening tools. I think that's really amazing. I was wondering whether you have tested or are planning to test your screening tools against other screening interventions, looking at whether they actually improve health outcomes in the end. And then Cato, also very interesting work that you are doing. I was wondering in concern to the systematic review that you did. So I assume that there you didn't only look at Belgian data, but it was kind of like internationally literature that you looked at. And I was wondering, because I myself is a part of a consortium working with digital health tools across several countries, and there we do, or at least it's my feeling that there are differences across countries in how people feel about data privacy and trust in technology. So I was wondering whether that was something that you also saw in your work. So yeah, that was my little bouquet. So.
Thank you.
Can I start?
Filipa?
Thank you for the question. In Portugal, we have one problem. A very sedentary lifestyle. The food is great. The alcohol is great also. So we have more many cardiovascular risks that are not diagnosed. So when I have a 50-year-old man who never went to primary health care for health surveillance, for me it's a problem because he has a high blood pressure, high cholesterol. So these risk factors can be managed before he had a heart attack. So if I make aware 30% of patients that your high blood pressure and your high cholesterol, please go to the primary health care center. So he makes more aware of health status and can prevent some future damage. This is our goal. I don't think I can keep.
I think I'm next. Thank you for your bouquet of questions. Yes, so that's the last phase, or the third phase. So we did all of these with patients, with clinical partners. Then we moved to designing and prototyping the intervention. So now we're moving to formal testing with in the US, R01 from the National Institute of Health. So that's where we are now. Yes, we need to test it, even though we adapted it from an evidence-based screening tool, My Own Health Report. When we adapt, we still need to test. Are we still getting the impact? But let me add, we need to add implementation cost. How much does it cost to do this way with active engagement? And that's an area that we're including as part of the. It's not just testing whether the screening tool is making a difference on better diagnosis and patient experience. For example, if a provider recommends a particular cancer treatment center or facility 20 miles away, but the patient say, I don't have transportation, we hope that the tool can help us connect the dots and now support and being mindful of challenges with transportation becomes part of decision making. But also cost of and impact of the implementation and the previous design and how we did this. So definitely the efficacy and effectiveness of the tool is part of the plan, but also the implementation piece. Is it really better to do it this way? And how much better? And what are the areas where we got it right by using a participatory user-centered design? Those are our next steps.
Thank you. I'm looking forward to seeing the result of that.
Yeah. And Cato, I think we are running out of time, so you have a fast answer.
Thank you for your question. I think, yes, the context is very important. I felt that as well going through my reviews. I think it depends, let's say, for example, the trust that is present in certain stakeholders. It really depends on, let's say, whether a privacy scandal has happened in a country or how much trust is present in the government, let's say. So that context is really important. And for my results, so my results will be published in a review of reviews. And I will make a distinction between location, let's say UK, US, China, Europe. And next to that location, in my context, the type of data is also very important. Genomic data versus other health data. So next to the location, that is very important to make a distinction. For me, it's also the type of data. Thank you for your question.
Thank you. Thank you so much. I would like to thank the panel for your presentations, very interesting, and also for your engagement in this discussion. And thank you so much to the audience also for great questions. And please, right after this session, the online, recording of this session will be on the ICI homepage. So please, if there's anything you missed, you can go back or share this session with some of your colleagues. So thank you so much, and thank you to the presenters.